Good morning. Greetings from the God's own country. Thank you, my dear Madhu, for this kind invitation. No. You would all agree that the extremes of cataract, both very hard and very soft, phacoemulsification is extremely challenging. In hard cataract, definitely it's a very hard nut to crack because of all these reasons: big nucleus, leathery one, shallow anterior chamber, weak zonules, poor endothelial status. So I've taken a case in which it has all these. In addition to that, you have the arcus senilis also. I'll explain why that is also important. Capsular rhexis is critical in these cases. The rhexis has to be quite big. It has to be at least 5.5 millimeter. And hydrodissection, you have to be extremely careful with hydrodissection. I usually do a cortical cleaving hydrodissection. In this case, I'll be very careful. Otherwise, you will find these cases have a very thin posterior capsule, and you'll find the nucleus in the vitreous after hydrodissection. And you have to protect the endothelium. Endothelium is already poor, and the surgery itself can cause damage. So you have to use something like viscode there. Different techniques are there. My preferred technique is the direct vertical chopping. You go in with high vacuum, hold it. When you're doing this, make sure that enough of phaco tip is exposed. Otherwise, you'll be just keeping on pushing on the nucleus and causing zonal dialysis. Once you do it, do a lateral separation, or you can actually debulk, chop it there, and then do the chopping. But what I prefer is saying it's your personal preference, and you rotate it. You can see that it's the nucleus doesn't separate that easily because it's a leathery nucleus. So one problem that happens with those who are learning initially is that you try to separate it very forcefully and ending up with zonal dialysis. What you have to do is you go very deeper in, go to a deeper plane and separate, and then it will separate. So once you get one separation, then everything goes off well. You have to, see the chopper, normally for all phacos I use a dialer only. Here I use a sharp 1.75 millimeter chopper. All the maneuvers are to be done in the iris plane or just below it to protect the endothelium. You're using more of phaco power, so it's better to go down. I mean, the surgery takes much longer, and the viscode you have put in gets washed off, and you have to keep refilling it. And this is the time when you can actually look for wound burn. The older phaco machines, the wound burn used to happen because of the higher power that was used. Now the effective power is low, but the viscode clogs the phaco tip, and this builds up the temperature in the wound area and causes wound burn. You have to be careful about it, and you have to be careful when you're managing the last bit also, because a lot of fluid would have gone to the Berger space, the potential space between the PC and the anterior hyaloid, and would push the PC up, and you can catch the capsule. This is one thing that can happen in these cases. You might see this patient came back 2 weeks after surgery, was okay initially, then came back with vision drop. There was localized corneal edema. I couldn't really see anything because there was arcus senilis, but I really suspected that there will be a nucleus bit there, and that is what was there. Coming to soft cataract, the challenges are different. Here, the issue is that you can't easily rotate the nucleus. Because it's so soft, you can't actually chop it. It's cheese-wise, and there will be loss of vacuum, and you might actually go through the nucleus and catch the PC. So this is what I do. I do a cortical cleaving hydrodissection, as I mentioned in the beginning. And so what I just do is I use a dialer only. I keep just nudging it and filling it into the phaco tip. So it works quite comfortably. See, in these very soft ones, it's not a good idea to actually try chopping, because it's going to cheese fire. So you just keep rotating, nudging the lens matter, and at the end, there is nothing, no cortex to aspirate. But if it is a bit more denser, then you can try chopping. So most of the cases, it works. The settings are kept a bit low so that it doesn't really go through it, and the phaco power can be near zero. I mean, you don't need much of a phaco power in these cases. You just need a bit of hold, one break, then everything goes fine. Then you keep rotating and feeding, and it gets aspirated, and again, because it is a cortical cleaving iorodissection, there is nothing to aspirate there. Or you can attempt a horizontal chop. I mean, there are many techniques that you can go for. I'm just showing a few. Everyone has their own favorite techniques. And see, this is one issue. If you're trying chop in a really soft one, then you will end up with a bowl there. You have a failed chop. But you don't have to really worry in these cases. It's a soft one. You have the handle there. Just catch hold of that, and then just flip it and aspirate. This is something that I downloaded from the net, the original chip and flip video from Howard Fine. You keep chipping on the nucleus, and whatever is there, left there, you flip it and then aspirate it. This is carouseling. This is the merry-go-round that you see in the melas. So you can actually do a hydrodelineation, get that nucleus delineated, and catch hold to an edge of the nucleus, and it'll keep rotating it. See, these are techniques that happen as you go. You record it and name it and present it. But if you're safe, you can even prolapse the nucleus into the supracapsular plane and aspirate also. These are the few techniques that can be employed. Thank you.